So just to get us started, kind of level set the webinar. As many of you know, pregnancy-related deaths and severe maternal morbidity is steadily increasing in the United States and has been for decades, along with the racial disparities that continue to persist. Providers, state health agencies, and national organizations have responded to this by developing review processes, data systems, and programs to increase consistency in care, improve collaboration and coordination, and strengthen data collection. Today we're going to be hearing from the CDC Foundation, the Association of Maternal and Child Health Programs, or AMCHP, and ACOG's Alliance for Innovation on Maternal Health, otherwise affectionately known by many of us as AIM. And lastly, but not leastly, we thought it would be important to illustrate all these efforts that are happening in these areas and have invited Michigan's Department of Health and Human Services and one of their key cross-sector partners to highlight their efforts in reducing maternal mortality. What they're going to do is be able to thread together today's information being presented and give you a good idea of how they've taken the data and used it to address maternal mortality. Our objectives today are to identify strategies for implementing and improving maternal mortality review processes, explore maternal mortality review and the data as well as how it's utilized, understand and describe the opportunities to address maternal mortality, specifically in relation to the AIM project, AIM Maternal Health Initiative that is funded through HRSA's Maternal Child Health Bureau. And we want to identify technical assistance and new resources available to address maternal mortality at the state, local, and national levels. So our first speakers today are Amy St. Pierre and Julie Zarnatos from the CDC Foundation, as well as Dr. Jeanette Kwolek from AMCHP. They're going to be speaking about the critical role maternal mortality reviews play with reducing preventable maternal deaths and some various tools and resources that are available to states. Ms. St. Pierre and Ms. Zarnatos work with the CDC's Division of Reproductive Health as members of the CDC Foundation team. They focus on building capacity for maternal mortality review through an initiative that's called Building U.S. Capacity to Review and Prevent Maternal Death. They provide technical assistance to support jurisdiction-level maternal mortality review, and in doing so promote a better understanding of the causes and factors contributing to pregnancy-related deaths. In turn, the increased level of understanding around the data is supporting opportunities to identify interventions and those really with the greatest potential to end preventable maternal mortality in the United States. And we also have Dr. Jeanette Kwolek with us, and she'll be highlighting a number of areas. She serves as the Associate Director of Women's and Infant Health at AMCHP. She has over a decade of progressive public health experience representing the life course in areas relating to maternal child health. Dr. Kwolek earned her degree in health sciences at the University of Wisconsin-Milwaukee, while she concurrently was working in the public health field. For those of you on the phone today, clearly our presenters are they're considered to be experts in the field and have quite extensive bios, but just to make sure that we allowed for most time to be spent on their presentations, we didn't go into great depth here. So if you're interested, we'd be happy to send you their bios. Just feel free to send us a quick email and we'll get that out to you. So with that, I'd like to turn it over to Amy and Julie. If you're ready, go ahead and take it away.
Yes, hi. Thank you, Christy. This is Julie Zafaratos, and thank you for having us today. We're happy to talk more about our work to build U.S. capacity to review and prevent maternal death. Great. So I was able to advance the slides. Perfect. So this first slide, we're looking at a challenge here today, which is maternal mortality. This visual is from the Pregnancy Mortality Surveillance System data. It's actually most recently released in the Green Journal just last month. And you can see here that the trend is going in the wrong direction. What you can tell that this is the pregnancy-related mortality ratio, which is looking at deaths during pregnancy and out to a year from the end of pregnancy. And so our colleagues here at the CDC Division of Reproductive Health have worked on this system for quite some time, and the authors on the most recent article include Andrea Krianga and Bill Callahan, and we are looking at what our leading causes of death are, right? So with the pregnancy mortality surveillance system, they include cardiovascular disease, infection, sepsis, hemorrhage, cardiomyopathy, embolism, and hypertensive disorders. And when we dig into the data a little deeper, we also see disparities by age and race, and they're quite significant as shown here. So we have a real challenge in front of us, and we need to develop some strategies to work together to address them. And so just to review the goals of our project, our goal is to promote maternal mortality review, the maternal mortality review process as the best way to understand why maternal mortality in the United States is increasing, and to prioritize interventions to improve maternal health. So in the last two slides, I highlighted findings from the pregnancy mortality surveillance system data, which is surveillance data. So this gives us a better view into maternal mortality, but state and local review committees give us the greatest specificity and opportunity to implement data-driven action. So our strategy is to provide resources and tools to support standard review processes that enable a common language for review committees. So while review committees happen at the jurisdiction level, the opportunity for reviews to, quote unquote, speak the same language when looking at maternal mortality indicators is an important one. So, so where are we with maternal mortality review committees in the United States? So the map at the left, we're looking at about 5 years ago, we estimated that there were 18 states and 1 city with existing maternal mortality review committees. And you can see there's quite a lot of momentum when you consider that today we have 33 states and 1 city with existing maternal mortality review committees. And what we're doing is going state by state, because all of them are at varying levels of implementation, and we're working with over 40 jurisdictions to support a standard approach to maternal mortality review. And now I'm going to hand it over to my colleague, Amy.
Thanks. This is Amy St. Pierre, and I work with Julie here at CDC. So we have seen that today there are a lot more states with maternal mortality review committees than there were just 5 years ago, which is great. But all of those states with existing review committees are at different points along the path to having a really fully functional, robust review committee. And we built this logic model here to help committees evaluate their own efforts. So you can look at this, and going from left to right, you can examine your processes to make sure that you're achieving your desired outcomes. So in that left column, you can look at your inputs and ask, do we have the necessary inputs, starting with authority and protections to operate, and going all the way down in that first column to define stakeholders and membership. And I also want to point out the assumption there at the bottom. You want to pay attention to that. Does your state have a PQC, a perinatal quality collaborative, a perinatal center, advocacy organizations, or some other infrastructure to support the implementation of your MMRC's recommendations? And if you are answering yes to these inputs and assumptions, then you can look over at activities and ask, is your state systematically identifying and abstracting cases, reviewing them periodically with attention to the contributing factors and opportunities for preventability? And do you disseminate your recommendations? Then when you've got these inputs and activities in place, that third column lets you look at your output. So are you putting out things like reports and presentations, maybe campaigns, trainings, and initiatives? And in this way, with these outputs, your recommendations become part of a cycle of continuous quality improvement for health systems. So moving over to those 3 outcomes columns on the right side, A fully functional maternal mortality review committee can really lead to adoption of policy changes by health systems and implementation of data-driven recommendations. So in the intermediate column, you see widespread adoption of patient safety bundles, which Deidre and Dr. Main will talk more about, and also adoption of policies that reflect the highest standard of care. You've also got access to holistic care for women and coordination of care across providers. So these are some of the outcomes that you see in the intermediate term. And then moving on to those long-term outcomes, let me see if I can advance the slide. So here in this pyramid, you see the cascading effects of a fully functional maternal mortality review committee. So not only are you eliminating preventable maternal deaths, but also looking at reducing maternal morbidities at all levels of this pyramid, and also improving population health for women of reproductive age. So we've developed a number of support tools to help states across all parts of this continuum. And so these support tools help you gather the inputs, conduct the activities, and achieve the outcomes necessary to achieve your desired outcomes. So we've developed the Maternal Mortality Review Information Application, or MARIA. We've come up with a committee decisions form that can be used by committees across the country and is being used to collect data in a standard way. Some mock cases to help you work through the process of a review if that's new for you. We've got some models for case identification. We've also developed an abstractor manual to help new and seasoned abstractors, and a committee facilitation guide that was developed in close coordination with Deb Birch, our abstractor extraordinaire from Florida, who I believe is on the line. And we've also developed some videos to explain the terminology involved in maternal mortality review and also the importance of maternal mortality review that can be helpful to share with leadership. I'll talk a little bit more about the data system. So MARIA, or the Maternal Mortality Review Information Application, is free. It's intended to be a one-stop shop, so you can abstract cases into the data system. You can develop case summaries, which you then disseminate to committee members. You can document your committee's decisions in the system, and you can use the system to analyze and report your data. And it's very comprehensive and has brought in a lot of different data elements that different states have expressed a desire to see in the system, but it's also standardized. It's built on lessons learned from several versions of a predecessor system called MMRDS, which we implemented with 12 different states from 2014 to 2016. And at this point, 33 different jurisdictions have requested to use MARIA. So there's a lot of exciting momentum there. The system lets you run some quick and simple analyses, like this little pie chart just shows you filtering by year and month of case review. You can look at your total number of cases by pregnancy relatedness. And this is just one example of a click button report that you can run. But of course, you want to go deeper in your analysis with your review committee data, and you can do that too. So you want to analyze on contributing factors to death, on preventability, and you want to look into your recommendations for action. So the system lets you do that, and we were able to do that using data from 4 states in a preliminary report from maternal mortality review committees. So released in February 2018, this report is a proof of concept that shows the ability to combine data from different states, and it includes data from 4 state-based reviews, those from Colorado, Delaware, Georgia, and Ohio. And it's also a tool for encouraging data sharing and collaborative data use. It's really the first in-depth look at contributing factors to maternal death, and the first time that we've been able to use multi-state data together to showcase opportunities for prevention. And for the first time, we have concrete evidence that a maternal death is not a single event. It's really the tragic result of the intersection of a number of contributors. related to the patient herself or her community, her provider, her healthcare facility, or systems of care. For example, the data shows that mental health conditions were a leading cause of death in these 4 states. And when we dig deeper, we see that factors at the provider, patient, and system of care level all played a role in these deaths. So the report demonstrates the role that MMRCs can play in reducing deaths of mothers during pregnancy and during or after delivery, and it's helped us cultivate social and political will for establishing and for further supporting review committees. And as more states participate in this kind of work, we'll increase our mutual understanding of these prevention opportunities and leverage economies of scale to improve maternal health outcomes. So I'll hand it over to Dr. Jeanette Kowalik at this point of AMCHP to talk a little bit about Review to Action, which is another of the tools we've developed as part of this initiative.
Thank you. So Review to Action is, as stated, a website that provides tools, resources, and support to establish a review, connect states to share best practices and build capacity, raise awareness of review committees' abilities to effect change, and eliminate preventable maternal deaths. So as you know, it is extremely important to provide your message, provide credible information. So Review to Action serves as a one-stop shop for information sharing as well as connecting with us. So we're very fortunate for this partnership with CDC Foundation and Merck for Mothers to be able to provide this resource to practitioners and families and other partners that are committed to eliminating maternal mortality. So the objectives of Review to Action: assisting states without an MMRC in gathering resources, tools, and support to establish an MMRC. As noted, oftentimes when others learn about the significance or the disparities associated with maternal mortality and morbidity, that there's a cue to take action and how do you get started. So the website provides a way to access information based off of where one is at, which is very helpful. There's also the ability to learn what's happening, get information on news updates. Maternal mortality has been in the news very much as of late. Fact sheets. There's the implementation part, as noted, where one is at and connecting them with the right levels to get started, as well as Maria. We also have the U.S. map, which provides access to state profiles and contact information. The Resource Center, which provides model resources and tools. And I would like to note that even meeting agendas are located here. We want to make it easy for states to move forward with their activities. And lastly, connection. There's portal stories, materials, discussion board, which is user or password protected, and also grief support.
Great. Thank you so much, Jeanette. And thank you, Amy and Julie, for your presentations. In the chat box, we asked everybody to, if you have questions, please feel free to chat them in. And what we're hoping to do is do a Q&A at the end of the presentations, just to kind of allow us to make sure that we get through and have enough time for everybody to share their information with you. So with that, what I'd like to do is move along to the to ACOG's Alliance for Innovation on Maternal Health. We have Deidre McDaniel and Dr. Elliot Main here to talk about some of the work that the Alliance for Innovation on Maternal Health is doing. So just briefly with their bios, Deirdre McDaniel is an AIM program manager with the the American College of Obstetricians and Gynecologists, ACOG. Has over 15 years of experience in maternal and child health programs at the state, federal, and local levels, as well as in the clinic. Her current role as a program manager, she works within the southeastern region of the United States, assisting public and private organizations with implementing and sustaining efforts to address issues associated with maternal mortality and morbidity. Dr. Elliott Main is the medical director of the California Maternal Quality Care Collaborative. Say that quickly a couple times fast. This is based out of Stanford University School of Medicine, and he's also the implementation director for the Alliance for Innovation on Maternal Health, or AIM initiative. He works also on the national project that is reducing maternal mortality that's based on ACOG, so this is all wrapped together. He's also a chair for the California Pregnancy Associated Maternal Review Committee and has served or chaired national committees on maternal quality measurement for ACOG, AMA, the Joint Commission, Leapfrog, and CMS. So with that, again, we definitely have their bios available for you if anybody wants to see their, a list of their more extensive experience. But just in mind of time, let's turn it over to Deirdre and Elliot. Take it away.
Thank you very much, and I'm very honored to be here. We're taking the baton from Amy, Julie, and Jeanette, and really talking about turning what we learned in maternal mortality reviews into action. This was sort of the theme of our last 10 years in California, and we'll talk about that at the end, where we took the lessons learned from 10 years of maternal mortality reviews and applied those to quality improvement projects. I'd like to start off by saying, though, that AIM, which is funded by Maternal Child Health Bureau, part of HRSA, is for the Council on Patient Safety, which is physically based at ACOG, but it really represents a host of organizations working together. And Deirdre will go into that in a few moments. We talked about the actual numbers. The CDC has recently released the latest pregnancy-related mortality rate, a little different from maternal mortality rate, but they go pretty close together. But actually, more importantly for public awareness is what's been in the news recently. There have been a whole series of stories in national news organizations. These are two that I would highlight and really recommend that you look at. One is in ProPublica on the web, highlighting a case in New Jersey, and as well as many others, of a neonatal nurse who died in her own hospital giving birth from severe complications of severe preeclampsia. So it can happen to everyone. She's a nurse, her husband's a physician, healthy woman, went into labor and delivery and passed away. Really a tragedy, but it brings to life the stories that we all deal with in maternal mortality reviews and in the numbers, and it's really important to have faces on our cases. The other side of the slide highlights a link to PBS NewsHour story. It was about 15 minutes on national news last week, describing the issues very succinctly, as well as some of the projects that are being undertaken to reverse it. I'd really recommend this for everyone in your state organizations to look at. Another recent story is in the New York Times. Again, just a few weeks ago, highlighting the issues in Texas, but as well as in the United States as a whole. The physician in the center of the screen is Dr. Lisa Ollier, who is actually going to be the incoming president of ACOG, and she has as her presidential initiative to reduce maternal mortality throughout the country. And what's important here is this also highlights that African American maternal mortality is 3 times higher, and in some studies even 4 times higher than any other racial or ethnic group. 3 to 4 times higher than whites, than Latinas, etc. And this is a national tragedy and a national disgrace that we should have so much disparity. This is the greatest public health disparity of any measure. So I'm going to turn it over to Deidre at this point, and she's going to go through the next set of slides.
Good afternoon. Again, my name is Deidre McDaniel. Thank you, Dr. Main, and I am the program manager here at AIM. And as we've heard so far, and not just Dr. Main's presentation, but the presentation before us of how the maternal mortality rate has just been increasing, we wanted to look at one of the ways that we are at AIM trying to address the issue. So our goal at AIM is to reduce maternal mortality by 1,000 deaths and to reduce severe maternal morbidity by 100,000 cases. And some of the ways in which AIM is working towards achieving these goals are by engaging multidisciplinary partners at the national, state, and hospital levels. And I think it's key to look at the fact that we're trying not just at hospital and state level, but we're trying to do this so that it's a national coordinated movement. We also have been developing and implementing evidence-based maternal safety bundles, which we'll talk a little bit later about in this presentation, and also utilizing data-driven quality improvement strategies. All right. But again, this effort requires national mobilization, and in order for AIM to be a national initiative, it takes many partnerships and collaborations, not only nationally at the state, local, and now as we're moving into opioid addiction, also at the community levels. So this slide just summarizes our partners that we're working with. One of the newer partnerships that we've established at the community-based level is National Healthy Start. Again, as we begin to embark on patient safety and quality improvement initiatives that are reaching outside of the hospital, you will see that we have begun engaging partners community-based with Centers of Medicare and Medicaid initiative, innovation as well. ASTHO is also one of our main partners, AMCHP, who's on the phone today, AWAN. And then we also have systems like Premier that are and Trinity that are national hospital systems across the country. Some examples of these partner contributions range from hosting national meetings to providing maintenance of certification credits for doctors, working on AIM to working with AIM to provide maintenance of certification credits for doctors to one of the things that ASTHO is doing is engaging state health officers to provide support. This is a listing of some of the things that, if you break it down nationally, the public health and professional organizations, perinatal collaboratives, Department of Public Health, hospital associations and professional groups, and then at the local level, hospital providers. At the national level, professional organizations have been working with AIM by engaging and coordinating their national partners and resources to promote AIM. At the state level, perinatal collaboratives and state agencies and hospitals work to support and coordinate hospital efforts. For individuals on the line who are members of ASTHO, one of the ways that you could support AIM efforts would be by making maternal safety a priority when structuring efforts in your state. And then lastly, as we move into implementation of AIM strategies, that would happen at the facility level or local level through implementation of the bundles that we have. As Dr. Main mentioned, AIM is funded by the Maternal Child Health Bureau through HRSA and was originally funded for 4 years to implement patient safety and quality improvement strategies in only 8 states. However, we are currently at 11 AIM states and systems representing 1.5 annual births. And as the program continues to gain interest and growth, the slide shows the different states that are actually seriously interested or interested in implementing AIM. As we continue to grow, we have the potential to extend to a total of 32 states with a collective impact of over 2 million births annually. I'll now hand it over back to Dr. Main to discuss the safety bundles that we have.
You all have probably heard about the national safety bundles that have been vetted by multiple professional organizations and hospital associations. What they represent is a checklist of items and practices that we think every birthing facility should have. whether you're a tertiary level facility, a rural level facility, a birthing center. These have been signed off by the American College of OBGYN, the Nursing Association, the Midwife Association, and the Birthing Associations. Now, they don't represent national protocols. Facilities will need to modify the content based on the local resources. Not everybody has advanced radiology techniques. Not everybody has a huge blood bank. But you should have a standardized approach to hemorrhage that meets your facility's resources. That standardized approach allows you to train, to drill, and to teach to it, and to have everybody be able to work as a team when an emergency happens. All of the bundles have a uniform structure. They talk about readiness, what goes on for every unit to prepare and educate for an emergency, how to recognize or prevent. So this is things that happen for every patient, typically before the event happens. And then thirdly, how you respond to an event. And this is really focusing then on the team approach and on supporting patients and families. Lastly, it's about learning from your experiences as you go. This is systems learning. It involves reporting and reviewing, and we've worked a lot with the Joint Commission on this one, as well as having some metrics that we can follow progress with. All of the bundles are available free and open source at safehealthcareforeverywoman.org, and they are presented with resource links to great detail about how to go about these. These are the bundles that are out there. In the pink, there are the 4 main intervention bundles: hemorrhage, severe hypertension, maternal venous thromboembolism prevention, and safe reduction of primary cesarean births. Hemorrhage and hypertension have been the first ones implemented by many states because they not only are the most preventable causes of maternal mortality, but they also account for 75 to 80% of severe maternal morbidity. Our next major goal in the initiative, and they are present in a very common rate. Hemorrhage occurs 2 to 5% of all births, and severe hypertension is also in several percent of all births. So these are common events that we can have a major impact on. Just released earlier this week is a new bundle with a very different task force on obstetric care of women with opioid dependencies. And this is one in which we have 4 or 5 states who are stepping up wanting to work on this as we go forward. On the lower left here, we have safety tools, which are specialized bundles for helping organize safe healthcare in your hospital, typically focused on early warning signs, case reviews, and patient family support. On the bottom right are bundles. Again, these are all multidisciplinary, created and supported by national professional organizations, focusing on reducing, these are just focused on reducing disparities, maternal mental health, and postpartum and intraconception care. Again, these would be for every mother going forward. Now, creating a bundle is far and away the easy part. Implementation is the hard part. It is a well-known phenomenon in medicine that a national guideline has taken, on average, 17 years to put into practice for wide-scale adoption. We really need, obviously, to reduce that greatly. And the goal here is to work through our perinatal collaborators, through our state health departments, through our state hospital association to move this forward in a very rapid way. We, at the national level, are supporting our teams by doing monthly support calls that allow for sharing of resources and ideas among all the different states and teams that are engaged, essentially creating a collaborative of the state collaboratives. We provide clinical and data technical assistance, and we identify and then can address common issues that develop, such as protocols for treating severe hypertension. We've addressed shortages of critical drugs in some of these areas that have come up. And we've supported specific process and structure elements. We have created implementation toolkits, or how to do these national safety bundles, and educational tools such as e-modules, a resource sharing, basically a listserv, and safety action webinars. Let's turn for a moment to see how they've done in one state. As we said at the beginning, I chair the Maternal Mortality Review Committee for the state of California, and this is what we were faced with to begin. In 2006, California Department of Public Health noted that our maternal mortality rate was going up, as was the U.S. The U.S. here is in red, we are in blue. California accounts for 1 out of every 8 births in the U.S., 500,000, so we're a big state, a lot of births and a lot of deaths. So we started reviewing these, and we've reviewed over 400 deaths now over the last 10 years, and have learned a lot about both the causes of death, but more importantly, what were the opportunities to improve care? And that was a really critical piece of our maternal mortality review process, is looking to the future of how we could improve it. We worked first on hemorrhage and then on preeclampsia and cardiovascular disease, are our major 3 initiatives in California. Started off first with hemorrhage and preeclampsia, and those are actually some of the best to start with because they create the teamwork and the infrastructure for quality improvement in your facility. We have changed our direction quite a bit in California. In the last, 2014 looks to be at the same range as 2013. And we're very different now than the U.S. as a whole. These are maternal mortality rates taken from the death certificate. Our pregnancy-related mortality rates are actually quite similar in California. And we are seeing a very large decline, as illustrated here. One of the main issues that we're working on across the country in AIM is actually treatment of severe hypertension. It works out that the major cause of death with preeclampsia is not seizure, but actually stroke, intracranial hemorrhage. It's what Lauren died of in New Jersey. And the key here is actually to treat the severe hypertension early and not let it burst a blood vessel in the brain. And here's 3 of our early states that are working on this, and we're up to 60% are treated within 60 minutes, so that we're making progress, not quite there yet, but this is very exciting that we can do that. So we want to thank you, and we're happy to take questions at the end, but these are our key leaders. So we are based at ACOG, but as again, we are comprised of every major maternity professional organization and many other partners. So let me turn it back over to folks at ASTHO.
Great. Thank you so much, Dr. Main, and thank you, Deidre. And I apologize for mispronouncing your name. It's the E at the end. Sorry. At any rate, thank you so much for that presentation. And what we're going to do is let Dr. Frank Anderson and Lynette Bierry with Michigan to give us a state perspective on efforts to reduce maternal mortality. Just really briefly, Dr. Anderson is a professor at the University of Michigan, Department of Obstetrics and Gynecology, with a joint appointment in the Health Behavior Health Education Department at the School of Public Health. Dr. Anderson is a generalist, obstetrician, gynecologist, and Director of Global Initiatives. Since 2001, Dr. Anderson has served on the State of Michigan's Maternal Mortality Medical Committee and is currently the Vice Chair. He also served on the Maternal Accident Committee since its inception. Dr. Anderson has published articles on ectopic pregnancy, sepsis, hemorrhage, and and hemorrhage in the state of Michigan, and currently serves on the Michigan AIM Executive Committee. Also today from Michigan, we have Lynette Bury, who's the current bureau chief at the Director of Family Health Services. Lynette provides administrative direction and oversight of the Division of Women, Infant, and Children. Let's see here, the Division of Immunizations, Division of Maternal and Infant Health, and Division of Child and Adolescent Health. So seems like our community health programs at the state level. She serves as the current Maternal and Child Health Director for Michigan. Lynette brings extensive experience in clinical care delivery as a certified physician's assistant, which adds to her professional portfolio of research, evaluation, program management, and administration, both in the private and public sector. So with that, I'd like to turn it over to our speakers. If you're ready, we're ready.
Okay, thank you. This is Frank Anderson, and thank you for inviting us and the representatives of the state of Michigan to participate in this talk. It's such a pleasure to see the MARIA program and the My AIM program as resources now for the state. Like she said, I've been on these maternal mortality committees and have worked quite closely with a variety of state workers on ways in the nitty-gritty of state work and day-to-day work and committee work to get a handle on maternal mortality in the state of Michigan. And it's still a work in progress, but certainly is rewarding. It's rewarding work for states that take this on. So I think in this presentation, Lynette and I will give you a little more of a granular approach on what has happened at our state as we've been doing these understanding of how to do surveillance for maternal mortality. We used to call it the maternal mortality study, now we call it maternal mortality surveillance. It's been critical that we understand the definitions of maternal mortality and that at the state we all come to the same understanding what the definitions are and how we're going to measure it and how we're going to report it. It's extremely important to understand the process that we have to go through to identify the cases of mortality and to review them and to get the results of those reviews into a format that we can use them. And that's why I think that the MARIA program will be so helpful for states that are just getting into this. But, at the state level, we want to know what is the risk that women incur as a result of pregnancy, and how can states provide to do this, and which numbers are actually real. We hear so many different numbers, and how do we really get to the granularity to know which numbers are real? And then, of course, what do we do about it? And that's why the AIM project has been so helpful for us. And this is the typical iceberg where maternal mortality is just the tip of the iceberg. And as we spoke before, maternal morbidity constitutes another huge problem. But maternal mortalities we can measure, and they provide some indicator for maternal health in our states. So just to take a quick look at definitions, the maternal death is the death of a woman while pregnant or within 42 days of the termination of pregnancy, irrespective of the duration and the site of pregnancy from any cause related to or aggravated by the pregnancy or its mismanagement, but not from accidental or incidental causes. So these are all the obstetric deaths, hemorrhage, preeclampsia, ectopic pregnancy. They wouldn't include suicides or homicides. We have the direct obstetric deaths, which are the direct obstetric causes like what I just said, and then indirect obstetric deaths where HIV or anemia or some other medical condition is aggravating the pregnancy. I'd also like to mention the maternal mortality ratio is the common measure of maternal mortality, and in this case, the numerator is the maternal deaths as stated in the ICD-10 definition, which is deaths while pregnant or within 42 days. And that's going to become very important as we talk further, and the denominator is live births. And so this ratio is expressed as deaths per 100 live births, You'll often hear it called the maternal mortality rate. The National Center for Health Statistics calls it the maternal mortality rate. But I do teach epidemiology at the School of Public Health, and so I like to stick to these strict definitions. But you'll also see the maternal mortality ratio, also called the maternal mortality rate. But actually, the rate is deaths per 100,000 women of reproductive age. So with the changes that occurred with the ICD-10 definitions, there was an additional O code, other indirect carnal death, and that O code can be generated when the pregnancy checkbox is checked on the death certificate. And so in many states, the death certificate now has a pregnancy checkbox. And if that pregnancy checkbox is checked, that automatically gets an O code and becomes a maternal death. So that switch is one reason the number of maternal deaths have increased. So in 2003, there was a revision of the U.S. Standard Death Certificate, which added the new codes for ICD-10 for deaths connected to pregnancy, childbirth, and the puerperium. And the death certificate contains separate questions related to the pregnancy status. So the maternal mortality ratio from the National Center for Health Statistics is derived directly from that death certificate information, and it is limited by the 42-day time period. And when you look into it, an official maternal mortality ratio for the United States hasn't been reported since 2009 because the checkboxes have been checked without verifying pregnancy, which has led to a lot of false positives. Now, in the state of Michigan, we've had to deal with this, and each state will have to deal with this as it comes. Our state maternal mortality data was being presented just with the checkbox. And just in the last 2 years, our Division of Vital Statistics has gone by and verified each of those checkboxes when there are no other pregnancy codes on the death certificate. So we'll talk about that more too. But that's been a very and complicated problem that we'd have to solve through strict processes in the state. Now, the CDC and ACOG have created some other definitions so we can have a more granular picture, and that's where we get the pregnancy-associated death, which is the death of a woman while pregnant or within 1 year of termination of pregnancy, irrespective of the cause. So this definition would include any woman who dies while pregnant or within a year of pregnancy. This could include car accidents, homicides, suicides, drug overdoses, etc. Clearly, some of those may have a pregnancy component to them. If you just weren't using your seatbelt on the highway, that would not suggest any increased risk of pregnancy. So it's very important to know when we're talking about maternal mortality what the numerator is. And so if it's all women who died while pregnant or within a year of pregnancy, that's the pregnancy-associated death. And then for pregnancy-related death, these are women who die while pregnant or within a year of the termination of pregnancy, irrespective of the duration inside of pregnancy. So that's more like the standard ICD-10 maternal mortality death, but it extends it out a year. It's very important at the state level to understand the differences between those. Now, the thing is, all of the pregnancy-related deaths will come out of that subset, will be a subset, of those pregnancy-associated deaths. So what we have to do is find all the pregnancy-associated deaths through matching death certificates and birth certificates, and then figure out which ones of those are the pregnancy-related deaths, and then look at those related to the cause of death. Now, just to show you from Bill Callahan's article, which is a great overview of maternal mortality in the United States and all these definitions, if you're interested, you can see that if you look at the maternal mortality ratio, at least while it was being published, was always less than the pregnancy-related mortality ratio. And that's because when you look out a year or past that 42-day point, you do find women that have died from pregnancy-related complications. Obviously, that occurred after that 42 arbitrary day period. You've seen this slide before. This is pregnancy-related mortality, and there is clearly an increase in the pregnancy-related mortality ratios in the United States that needs to be addressed. And you can also see the distribution of causes: cardiovascular disease, other medical non-cardiovascular diseases, hypertension, hemorrhage, cardiomyopathy. We're seeing more and more cardiomyopathy, which I think is a good reason why we do surveillance in the state of Michigan, so we can monitor the different causes of death and their incidence. So now I'd like to turn it over to Lynette Berry to talk about a little more about the history of the Michigan maternal mortality surveillance.
Thank you, Frank. Good afternoon, everyone. I'm happy to be here to have a few minutes to talk with you about Michigan's long history with maternal mortality surveillance. It dates back to about 1950 when the Michigan Society of OB-GYN, along with the Maternal and Perinatal Health Committee of the Michigan State Medical Society, reviewed cases only in the Detroit area hospitals. Sometime later in the 50s, that was expanded to be a statewide review. And then fast forwarding to the mid-1980s, when the CDC and ACOG established the National Pregnancy Mortality Surveillance System, which Michigan signed on to at that time. Key to our efforts is that in 1989, our state vital records began electronically linking birth and death certificates. And as you can tell from what Dr. Anderson was just saying, that's relatively key to our process here in Michigan. In 2002, we added the accident and injury cases to the review process. And in 2004, Michigan Vital Records implemented the pregnancy checkbox on the death certificates, which of course helps identify cases, but also requires due diligence to ensure that those women indeed were pregnant. We get a certain number of men with that checked off, of course. We also passed a statutory requirement in Michigan to report fetal deaths of 20 weeks or of a weight greater than 400 grams. In 2005, the current Michigan Maternal Mortality and Morbidity Surveillance Committee was established interdisciplinary committee, to review and prioritize preventability recommendations and move toward public health implementable actions. In 2014, the committee and the Michigan Health and Hospital Association, or MHA, through a Keystone OB project, implemented the hemorrhage safety bundle. And as of starting in 2015, we've had multiple research initiatives that came out of all of the data that's been collected through the years, including papers written by Dr. Anderson. We have also began working with CDC's pregnancy mortality surveillance system. We're hoping to actually electronically be submitting to Maria relatively soon. And in 2016, as one of the previous speakers indicated, we became one of the AIM states. Let me talk for just a few minutes about the current organization. As I think one of the speakers from the CDC said early on in the presentations, prevention requires partnerships and collaborations, and that certainly is a critical piece of how Michigan approaches our surveillance and review committee. As also was noted earlier, maternal mortality is multifactorial. It is not any one issue. It's the social determinants of health, the clinical care system, as well as that individual woman's health history. So we need cross-system interventions and collaborations if we're going to truly impact this issue. So we have a very broad and really even currently kind of growing the partners that are involved with maternal mortality surveillance, all the usual suspects from ACOG to the nurse midwives, the psychiatrists, the State Hospital Association, maternal fetal medicine, and so on. They're represented on that slide, as well as a number of the state and local public health entities, and even the Department of Transportation within Michigan. We have individual committee members that represent all the obstetric areas of medicine that come from Medicaid policy in the state, social work, law enforcement, and local public health. And I will, with that, turn it back over to Dr. Anderson.
And so we do have two different committees in the state that have been established, as you have been able to tell. And the first step, of course, is finding the cases that we're going to review. There is a voluntary reporting aspect to it, but I would say that in most cases are obtained by taking the death certificates of all the women who died the previous year and matching them to birth certificates and fetal death certificates. And then, of course, looking if the death certificate has an O code that would suggest a pregnant woman who had died. Those cases are all collected through the activities of the state. The charts are requested, and believe me, it's quite an effort on the personnel who have to obtain those cases and the charts so that physicians and other committee members can abstract those cases. They do divide them into then the medical case reviews and the injury case reviews, and then those committees are each assigned the appropriate cases for the committee, and then they're reviewed, abstracted, and presented at the committee meetings that occur approximately 4 times per year. I just wanted to share with you this recent and exciting development in the state of Michigan. The state, the governor has signed a bill that makes maternal mortality, quote unquote, a reportable condition in the state of Michigan. And although we were voluntary reporting before, now the hospitals are all coming together in a way to establish a process that would identify maternal deaths and then become reported to the state so that we can assure that the cases that are occurring in Michigan are being ascertained and reviewed by the state. So this was one of the activities of the committees. It's been a long time coming, and it's a very good bill in terms of voluntary reporting, but it also adds a whole sense of urgency and importance to this issue in the state. So I know we're one of the few states that has this bill, and certainly it's something that could be pursued in other states as well. As I won't repeat the definitions, but we have to make sure we make the distinction between pregnancy-associated deaths and pregnancy-related deaths while we're working through this. And here is some raw data. We're still working on our annual reports. We had many years where data wasn't complete, due to a lot of different challenges that we faced in the state. But in 2007, we had 88 cases that we reviewed, and we found that 18 were pregnancy-related, 47 were pregnancy-associated, not related, and then there were 6 that were undetermined. 16 of those 88 cases were simply not pregnant, so that gave us a high false positive rate, not reviewed unknown pregnancy 1, and you can see similar numbers for those other states. But when we start looking at these actual numbers for pregnancy-related death, we find they're a lot smaller than we might have expected, looking at the larger, kind of more general maternal mortality ratios that we're working with. And here you can see the ratios in the state of Michigan, pregnancy-associated and pregnancy-related ratios, and the differences between those two. The pregnancy-associated is always going to be much higher than the pregnancy-related ones. In our injury committee, we're finding that the most common cause of death are motor vehicle accidents, violence, intimate partner violence, and suicide, and the third most common cause is substance abuse. And then if you look at all cases, we found that obstetric cases are about 30% of all causes. Medical, non-obstetrics are 16%. These will be cancers and other chronic conditions that cause the death but weren't actually obstetric causes. And then accidents, assaults, suicides, and other. One thing that we've been working on in order to help us determine the best interventions that would reduce maternal mortality is determining whether the case was preventable or not by primary prevention. If that was the case, health promotion, health education, policy, laws, and programs, what kind of activities in those realms could prevent future similar type of death. Secondary prevention are places where there were errors made in screening, when early detection didn't happen, or high-risk referrals didn't happen. So had those happened, perhaps similar deaths in the future would not be prevented. And then the tertiary prevention is the quality of care, this rapid response care, having blood transfusions, appropriate care for preeclampsia, ectopic pregnancy, et cetera. So when we separate those into those different categories, we're able then to suggest implementation activities in those different realms. So I'll turn it back over to Lynette.
Oops. I think the key that I would encourage any state looking to get involved with maternal mortality is there has to be a significant level of commitment of all the partners around the table. And certainly if your Department of Health is going to be involved and lead this effort, it requires a significant level of commitment because, of course, we are all functioning in an environment that we do not have enough resources. So there's always competing priorities, and this simply has to be made a priority. There's a need for a strong role of your vital records and Department of Epidemiology, depending upon how that's organized within your state. Things are constantly changing, as I think we've illuminated here, from the definitions of maternal mortality, and of course, the switch between ICD-9 and ICD-10 has changed things in the last few years quite a bit, as well as changing medical conditions, increasing obesity, diabetes, for instance, and Dr. Anderson spoke a few minutes ago about cardiovascular issues becoming more prominent in the state. So it requires kind of being pretty nimble and on your feet to think this through and have a process and protocol in place that captures all of these things that are changing in the environment. We, of course, have a goal of eliminating maternal mortality in the state of Michigan. Certainly would like to reach the global goal by 2030. We are working to tighten up the definition of preventable maternal mortality, establish processes and quality of care standards throughout the state through programs like MyAIM, as well as local programs. We do have quality improvement collaboratives at a regional level around the state. They do not completely cover the state as of yet. We're hoping within about a year that they will. In the past, they have worked a little more on infant mortality reduction, but those groups are starting to, as we move forward with AIM, get a little more involved with the maternal mortality reduction as well. We want to spend a little more time focusing around the state on our near misses and preventing those from becoming a maternal death for another woman. I think we all agree that each maternal death has something to teach us. I think Dr. Elliott said earlier, the cases have to have faces, and I think that from a communication perspective, particularly with stakeholders in Michigan that have resources to bring to bear on this, we are beginning to think about how to communicate those cases with faces. The maternal mortality surveillance systems are very complex. They require meticulous attention to detail. As Dr. Anderson said a minute ago, it requires a significant commitment of staff who are pulling these cases together. You have to be very attentive to the details. And we have a lot of opportunity in Michigan, as do others, I believe, to apply what we are learning in these case surveillance review settings to prevent women from developing morbidity, severe maternal morbidity, as well as dying from childbirth. And I believe with that, we'll turn it back over to the chair of the webinar.
Great. Thank you so much, Lynette, and thank you, Dr. Anderson. We do have quite a few questions that have come into the chat box. What I thought we could do is I'll just read them off. I believe the questions might be indicative of our presenters, like who should respond, but there might be a couple of different perspectives on questions. So what I'd like to do is start off, and we have a question from Nevada, Dr. Eisen Azam. Hi, Eisen. I came from Nevada. Dr. Azam is Nevada's medical epidemiologist. He has a couple questions here, and I believe this is towards Michigan and Dr. Anderson. Dr. Azam says, questions, did you observe any increase in the number or frequency of maternal mortality in Michigan since it became reportable, so around maternal mortality becoming reportable? Has there been any differences? And perhaps it's too soon to tell, but you might have some just initial thoughts on that, Dr. Anderson?
Right. So the bill was just passed earlier this year, so states are still, hospitals are still figuring out ways to do that. I'm on the Michigan hospital as we try to figure out how to actually do that in a systematic way. My suspicion is that they will have. I think we'll have a more accurate sense. I think that our goal at the state is to feel comfortable, and the committee members, and for all of us to say the ascertainment has been complete, and these are accurate numbers. And so I think that whether it goes up or not, I think the confidence in our numbers will definitely go up.
Yeah, and that makes sense.
This is Elliot in California. I'd just like to add to that. Ascertainment is the biggest bugaboo here. And the gold standard is to link birth and death certificates together, so you can look at any death that occurs within a year of a birth. That obviously misses miscarriages, but that's not a big contributor overall to maternal mortality. Michigan's been a leader in that, and the more you can automate that to do that so it doesn't take a couple of years to get that done, which is what it's taken in California because we have so many births. But so having reportability actually can help make it more quick. If you are going to miss cases that way, people who come into the ER or to the ICU, they may not realize that they should report them as a maternal death. So it's really, you have to have a couple different ways to ascertain cases that supplement each other.
Yes, thank you so much for your input, Dr. Main. So with that, there's another question for Dr. Azam. And can you go up the screen a little bit, please? Bring me back to, yes. So this is appropriate. What are the steps that a state is required to take to have in place in order to qualify to join AIM? And I know that one of the first things on this project is having a maternal mortality review in place, but perhaps ACOG could speak to that.
Sure. On our website, we have the criteria for this is at safehealthcareforeverywoman.org. But essentially, we really want you to have a state quality collaborative, perinatal quality collaborative, or something very close to that. And every presenter today was really talking about the keys here, which are partnership and collaboration, and that's really what we're looking for. So the State Hospital Association is an important partner here, as well as the professional organizations with the state health department. So all three legs of that stool have to be able to show that they're engaged and working together, because it is really hard work to get the bundles implemented. And to get the in and outpatient, as we work toward opioids, that's really a lot of outpatient work. And that's a lot of coordination and a lot of communication. So it involves a lot of partners and a lot of collaboration. So the prerequisite is really having the professional organizations, the hospital association, and the state health department really come together and say they want to work on these and that they have a structure to work within. And that's it.
Yeah, and that makes perfect sense. And we hear that a lot where I think oftentimes at the maybe maternal and child health program level, there's an interest to address this. But really taking a look to see how you can engage senior leadership at a state health department to really, if there's been perhaps barriers or maybe a lack of interest, I think oftentimes perhaps senior leadership at a state health division, like a state health official, a senior deputy, your state epidemiologist, sometimes involving people at that level might be able to drive some of those partnerships, and then kind of be able to pair those with the relationships that have likely already been developed at the program level. So just creating that nice cross-sectoral and like a strong commitment to the overall area of being able to address maternal mortality. So we have a question from Brandy Wells, and she has a question about if there's anybody that can speak to the legal considerations in maternal mortality reviews. How do other states protect their MMR committee members from being subpoenaed? Anybody able to answer that question from our panel of experts?
Hi, Brandy. This is Julie Zaharados at CDC, and I'd be happy to talk more to that. Actually, we worked with AMCHP and ACOG to develop an authorities and protections checklist, and I can share that with folks. I can send it to our ASTHO partners who can distribute it. But we're really encouraging folks that may not have dedicated maternal mortality review legislation in their state or jurisdiction to look at three main components. They should look at addressing the authority to access data, the confidentiality and protection of collected data, the proceedings of the committee meetings and activities, and immunity for committee members from subpoena. And I can share that if it's helpful, because as Elliot said, it's really important for you to be able to identify cases by linking birth certificates to death certificates, and that's really the first step to the process. And if you don't have adequate protections, it might be really hard to get started.
This is a question that's very commonly raised, and it really is a state-by-state analysis. Some states have it within their public health authorizations to review cases in an anonymous way for public health purposes, which is exactly what this is. Other states really demand or require extra legislation to ensure that that physicians who participate aren't subpoenaed for their opinions on the very same case. Most of these states, my state for sure, do these case reviews anonymously, or de-identified, so we have no idea either the name of the woman who passed away, the hospital identifier, or the physicians engaged, and that's probably an ideal way of reviewing cases, which is helpful for this process too. Obviously, in a small state, you have a very small number of deaths, and that makes it a little harder. But this is an important step, and I think the CDC has done a great job of pulling together the examples and resources to address it.
In Michigan, there's a couple of issues that come up as well. We do have legislative protection from the committee findings. They're non-discoverable. But I think that in terms of the physician abstractors, there's also legal considerations. They do have a contract with the state, and and have signed, agreements, and those are managed. Those contracts, those annual contracts, are managed by the state, and so those abstractors do see the non-identified information, but the rest, the committee members only see the de-identified information. Number one, and number two, it's important that the providers in the state know that the committee activities aren't investigating in a way that would be punitive for them individually, because that's not our recommendations are all at the policy level. I think we're assuming that quality of care is going to be taken care of at the hospital level and at the licensing level, and there's no interaction between the state review committees and anyone's license, any hospital's license, or any individual, punitive action. So that's obviously not the case in many countries, but I think it also needs to be clear, and it is always made clear every year when the state sends out the letter that it's not that type of it's not a threat in that way. It's only a learning opportunity.
Thank you. We have about 7 minutes left, and we have a number of questions coming in, so I'm going to try to triage them, and if we don't get to them all on this call, what we'll do is collect them for our presenters and create a question and answer form that we'll be able to send back to all the participants. This one I think is pretty relevant. The question for Michigan: what were the lessons learned from the bill on mandatory reporting on maternal deaths? So thinking about the legislative process, all the way from the concept probably through some of those layers that you have to get to be able to move that forward. Was it a state-sponsored bill, or was it maybe a partner-sponsored bill? How did that come about, and were there any important lessons learned that other states can learn from?
Lynette, do you have any comments?
Hi, this is Lynette Fury. So I'm relatively new to my position. I've been with the state for about 9 months, and this bill predates me. So I have a few comments, but I don't have probably the level of detail. The quick answer is that this was very much spearheaded by a maternal and child health advocacy group, and they did the heavy lifting. In Michigan, our public health code does not allow us to actually interact directly with the legislature and propose any bills. So it was external partners that really did the heavy lifting on this.
I think that there was an engagement with one of the legislators who took it on, and that was a relationship that existed, I think, between some obstetricians and gynecologists in the state who were also on the committee with that legislator. We had to testify, obviously, at the different levels, but I would say that there's no specific lessons learned other than how to get a bill passed and how to frame that in the correct way. I think that Michigan was a state that was ready to do something like that, given some of the other public health issues that we've had in the state. So I think it was fortunate that it came up at the time that it did.
Great, thank you. Before I go on to ask another question, does anybody have any questions they want to ask on the phone? That's also an opportunity. My personal preference is chat boxes too. All right, so while we're waiting, perhaps just one more question. From experience, how do states decide, which bundles to start from? I know, there's probably some of the obvious ones around hypertension, but have we gotten any feedback from any of the participating states in AIM around, how they dove into the project program?
I think there's two considerations. One is, what are you finding out in your maternal mortality review committee? It's actually interesting as we work with different states that there are different issues in different states, which is one of the keys to why you should have a local maternal mortality review committee. New York City has very different sets of issues than they do in Utah. And you really want to be able to address what's the most important issue locally in your state. So that's number one. Number two is, what can you do that's going to give you some quick wins? And the quick wins are both in terms of engagement of your partners and in terms of moving the dial and engaging physicians and hospitals. And so that may be a factor in your first choice of, we've recommended hemorrhage being a first one out if you haven't worked on that, because that does meet that quick win scenario. Other states are really looking at the opioid bundle for that now, as we've been into this several years, and opioid dependency is emerging as a big issue for pregnancy. The opioid bundle, I know there was a question on that. The opioid bundle is available on site, and it really is focused on how to coordinate care, how to do the communications, and link in and outpatient care. So it's a lot about those kind of factors, and it really underscores the issue that all of these bundles need a lot of partnerships because an individual doctor can't do that alone, or an individual hospital, that you really have to be able to coordinate the care between public health in and outpatient services. And as we all know, outpatient services for pregnant women with opioid disorders is a big problem in the United States. And we really are trying to look at best practices to how to bring that into the communities where it's needed.
Thank you, Dr. Main. And I feel like I could talk about that issue for hours. Our ASTHO's president, Dr. Jay Butler, who's the state health official for Alaska, his presidential challenge this year for ASTHO was substance misuse and addictions. And he's really interested in this whole concept of secondary prevention, so being able to identify women or pregnant women with substance use disorders and turn that secondary prevention piece, so identification through screening, into treatment, and then this whole concept around primary prevention, so secondary turning into primary prevention, and allowing the identification of that substance use disorder to become a mechanism perhaps to address some intergenerational or cycles amongst families. So with that, we are at time. I wanted to thank everybody for their presentations today. We truly appreciate your time. Like I said, we will post some of the questions that came up for our speakers, so perhaps we'll get some more detail on that. There's lots of opportunity based on some of the questions that did come up for us to be able to provide back to you all. I'm going to go ahead and turn it over to Ify, and she'll go ahead and close.
All right, and thank you everyone for participating on today's webinar, and thank you to all the speakers for supporting ASTHO to host this webinar. Shortly after the conclusion of today's webinar, you will be emailed an evaluation survey. Please take the time to answer the evaluation survey. Your feedback is greatly appreciated. The slides and recording from today will be posted on ASTHO's website soon. For other updates and resources, please visit our website, www.astho.org, and the websites of our partners. And with that, one, you'll also notice that there is a new resource that was just released on our website on Michigan's work around maternal mortality. And please do visit that site, click on the link, and see that state story that highlights their work. With that, thank you, and have a great rest of your day.